as far as he needed to smack me with his big Austrian noodle upside the head because he was pissed off about me saying that qualitative research is not useful to you, and it's not. Okay, I don't bash qualitative research. I think there's really great qualitative research. As a matter of fact, sometimes you need a qualitative study in order to design a quantitative study. For example, if you're going to go out and you're going to ask people, are you just going to assume you know what people's concerns are? If you're going to do a study that's going to ask about their concerns, like let's say you're dealing with, I don't know, patients having laparoscopic cholecystectomy, and you make a list and you say, well, I think their concerns are PONV, post-op pain, make a list of a couple of things, wherever there are. Now you give people this survey. What's your big concern? And okay, it's like, well, my biggest concern is being able to, I don't know, cook afterward, something stupid, being able to go roller skating or something, afterwards, and it's not a choice on the list, right? It's not a choice. So now, if you design a qualitative study where you ask people, what are your greatest concerns regarding your surgery? And let's say you have 100 pre-op laparoscopic cholecystectomy patients. You interview them, and in those interviews, you pick up themes, right? People will say, if it's post-op nausea and vomiting, or if it's post-operative pain, or if it's ambulation, or if it's roller skating, or for whatever it is, they want to do. And so once you've picked up on those themes, now you're in a better place to design a tool that's actually going to ask them what they're concerned about, right? Make sense? So qualitative study is not crap, okay? Even though some people say it is. I'm not, and that's not what I'm saying. For your purposes and looking for evidence for your EBP project, qualitative research isn't going to help you much, okay? For the most part, qualitative studies are probably not going to give you strong enough evidence to show that that it's at a high enough level to show that it's going to work for you. So quantitative terms, subjects, participants, respondents. In qualitative, you've got more participants, informants. It's phenomenology. Was it Heideggerian humanetics or something it's called? It's this whole thing about the perceived life experience and all this other crap they do in qualitative research that I don't understand. But I understand it, but I just choose to not think about it. And then of course, data narratives are, I participated in a qualitative study when I was in my undergraduate program, and it was on this is a blocking on it now. It was about elderly dependent persons at home. I'm trying to think of the beginning of it. Coping and stress among caregivers, lay caregivers of elderly dependent persons at home was the study. So they were looking at what were the concerns of lay caregivers who had elderly dependent people that they took care of at home. And you see we're in with specific open-ended questions, and then just let them ramble and record it. All I had to do was record it. I didn't have to do anything else. So study, subject, and or participant, obviously the people being studied in the area are being looked at. Site could be the overall location. So for example, you're probably gonna run into, especially in some of your systematic reviews that you read, or in some of the RCTs that you read, they may be multi-center studies, and that's good because the more you add to the end, the more likely it is to have some look a little bit more like a quality study. Like say multi-site studies, you'll see those, a lot of those. And it's good. And it's good to do multi-site studies. And one good reason I can tell you from anesthesia was that if I'm repeating myself, just let me know because I may have already told you this story, but when sevoflurane was invented, did I tell you that? All of the initial MAC calculations for sevoflurane were done by Edmund Eater, who recently passed away, who at the time was at the University of Utah. and he was doing studies on the macrocebal flooring. Well, it was all of those studies were done in Utah. What is one thing about Utah that's different than the rest of America? Okay, culturally. They're pharmacological virgins. They don't even drink coffee, right? So now you're going to study a drug on people who don't take drugs. And now sevoflurane comes out, and the initial MAC for sevoflurane was 0.7. Guess what? When you put people at 0.7, guess what happens? Nothing, right? Or maybe it was 1.7, I don't remember. It was low, it was really low, their initial MAC group. So again, multi-center studies pool data and probably come up with a little bit better of a, average, right? Because you're probably not going to get the same level of induced liver enzymes in Salt Lake City, that you're probably going to get in New York City, right? It's different. So people are just like, this stuff doesn't work. When Versed, and I was around when Versed was invented. Thank you. I know. The initial dose recommendations in the package insert for Versed when it very first came out was 10 milligrams. That was the dose. They were killing people. So, and again, that was a single center study. God only knows what population they were working with. I'll overshare here. When I had my colonoscopy done a couple of years ago, I'm due for another one next year. It's okay. So my IV's in my hand over here, and I got up here, and she pushed 70 milligrams of propofol, and that was all. Dude, I was done. It's the last thing I remember. So you give me 10 milligrams of Versed, you're probably going to kill me. I passed a kidney stone many years ago. I went to my wife was the manager of the emergency department where I went. And so one of her docs had thought he was doing me a big favor. Someone came and gave me 2 milligrams of Dilaudid IV. I thought I was going to die. I would lay there and can I at least get a pulse ox? Something? Anybody? I'm not on a monitor. So finally, it's fine. You want a pulse ox? Here's a pulse ox. They gave me one, so I put it on my finger. And I'm sitting there and I'm watching, and I had absolutely no desire to breathe. None at all. It was amazing. I would sit there. I didn't feel hypoxic or anything, and I could get that thing to. It was like a game. It's like, let's see if I can get to 82. It was that bad. It was that bad. I felt awful, and my pain didn't change at all. So opiates and I are not. We don't get along well. I took a Percocet after my wisdom teeth threw up. So I said, I'm done with that. So I took one. So I've taken one Percocet my entire life. But anyway. So, is the following statement true or false? Research involves researchers involved in quantitative research commonly engage in field work. False. They do not. Concepts are abstractions of a particular aspect of behavior, whereas constructs are slightly more complex abstractions, and then theories kind of knit the whole thing together. And I'm not going to rehash Dr. Robinson's class that I know you all enjoyed so much. But we don't talk a lot about theory in the DNP. Now, that being said, you are going to run into people who are going to want you to choose a theoretical framework for your DNP project. I'm not one of them, okay? But there are some people out there who believe that you should have a theoretical framework for your. So when I did my dissertation, you have to have a conceptual framework for your dissertation. And in my dissertation, I figured if they're going to make me have a conceptual framework, I'm going to pick something that nobody understands, because this is going to be a challenge to me. So I picked Margaret Newman's Health as Expanding Consciousness, or Theory of Health as Expanding Consciousness. They were completely lost. So I did that on purpose because everybody uses. There's like 3 or 4 of them that everybody uses, But anyway, so theories, constructs, concepts, right? Variables, characteristics or qualities that take on different values that from one person to the next. Blood pressure, weight, length of hospital stay, all those things. The problem that I find with variables is that most people can't tell me the difference between independent and dependent variable, right? So there are continuous variables. So versus categorical variables. The continuous variables are things you have to think of that can be on a continuum, right? Weight can be from here to here, right? Whereas either you're married, divorced, or remarried, I don't know, single.
It's complicated.
It's complicated. Good one. Yeah. So, independent, dependent variable, I think we beat up a lot. So, the presumed cause is always the independent variable, and the presumed effect is always the dependent variable, right? So, and that's where it says, like, smoking is the independent variable to lung cancer is the dependent variable, right? Overeating, obesity, poor diet, high, whatever, cholesterol diet, whatever, heart disease, whatever you want to say. Independent variable causes is usually the presumed cause of the dependent variable. Anesthesia school, insanity, it's all so. And then outcome variables obviously are outcome variables. Now the one thing I don't think they talk about a lot in this chapter is confounding variables, right? So sometimes in research you'll find confounding variables, which are things that were difficult to control for, right? So, or sometimes after study, the worst thing about doing a research study is that after you've collected your data, you always think of something you probably should have done that you didn't. Now you don't have that data set, so now you're going to dancing around it, right? So, conceptual definitions and operational definitions. Conceptual definitions are those abstract or theoretical things that are kind of really difficult to, the concept, maybe you're saying like self-care, or concept of like locus of control, something like that. Whereas operational definitions are kind of more like things you measure, right? So the things that you actually want to see. So in your studies that you're going to read, when it comes to looking for evidence for your project, you're going to be looking more at the operational definitions, because what you want is you want to try to match those with what it is that you're actually looking for. When you go to write your PICO question, you should pre-think about what are the key words that you're going to use in your search, right? And are those key words in that PICO question? Because they really need to be, right? Because remember, your PICO question is what drives your literature review. It's not, let's go find literature, and if we find enough stuff in one thing, let's design a PICO question. I see people do that, but that's not how it works, right? If you're a Melnick, like, purist type person, then you're writing the PICO first, and then letting that drive literature review. And then from that point, what really makes me crazy is when in the O, when you have already predetermined what the outcome is going to be, to a T, what exactly it is. And I try to steer you away from doing that. I would rather you say the outcome be a change or improved something or whatever, rather than saying an exact thing. Because now, remember, that exact thing you said in that O, now it becomes one of your keywords in your search, right? And so now what you're going to do is you're going to find out when you think that the deleterious effect of hypothermia, and like let's say you're doing a study like they're doing, like the class Patty is doing, where they're looking at pre-warming patients, right? Does pre-warming patients having general anesthesia for blah, blah, blah surgery, as opposed to no pre-warming, do those patients have higher temperatures in PACU, let's say, right? So if you say higher temperatures in PACU, now you're kind of tied into pre-warming, perioperative, and temperature. And you may not find a lot. When you find out that maybe pre-warming improves their discharge time, right? Or something, so what I'm saying, you narrowed yourself to the point where now you're looking at one thing and you may be missing out on something else that's important. So the outcome is kind of vague, right? So for me, rather than saying have higher postoperative temperatures, I would probably say have better postoperative outcomes. Because then if I leave it open at outcomes, now that gives me an opportunity to look at the literature and let's see what the literature says, and maybe there might be something that's more important than just their actual temperature on admission to PACU. Maybe it's they're less bleeding. Maybe it's less, or shorter PACU stay. Because even though people will tell you that money and cost is not an outcome, do not be fooled. It is an outcome, right? Because if you can save the institution money, they're going to like you, right? That's one of the biggest problems that we have in anesthesia nowadays. There's two big glaring problems that I see and I talk about, and nobody really cares. Is cost-effective or fiscally responsible anesthesia, right? This is going to sound terrible, but I'm going to say it anyway. And if you are working at a place that does a high private pay population mix, right? So you have patients, private pay basically means they're not going to pay. It's not going to happen, right? Is that the person that gets the remifentanil propofol infusion with Nimbex for muscle relaxation and Sugammadex for reversal for lap pulley? No. You know why? Because that anesthetic costs about $100,000, right? If you can show me in the literature where it says that it's a better outcome than propofol, sevoflurane, fentanyl, neostigmine glycopyrrolate, then I'll change. But my anesthetic that I just planned on someone who I know the facility's going to eat the cost of is about 1/10 of the cost of this other. So think about things. Be fiscally responsible in your anesthesia, because what happens is it comes back on your department when you're spending a lot of money, and it affects the bottom line, right? You have to think about these things when you're planning your anesthetic. And I'm not saying give a cheap anesthetic to someone who's not going to pay their bill, give an expensive anesthetic to someone who is. It's not what I'm saying. Because if that situation calls for the other thing, then I'm going to do it. If they come in renal failure, I'm going to use Nimbex on them because it's probably the safest, because it's the least metabolized or dependent on renal perfusion and on renal excretion, right? I'm not going to give them something that's going to endanger their life. I'm not going to do that. What I'm saying is, if you can't prove to me that there's a difference in outcome between this technique or this technique that's 10 times more expensive, I'm going to do the less expensive technique. It only makes sense, right? And then the other thing, we lived in a bubble for 25 years that I've been a CRNA. We've been in this bubble where people think that your responsibility for the patient starts when you meet them in pre-op holding, and you're complete and total, you are absolved of any responsibility for anything after reported PACU. And that's not true anymore. Now, every decision that you make in that operating room has an effect on that person's outcome. And in your lifetime as a CRNA, I promise you that insurance companies and other people will start mining and collecting data on your individual outcomes. And they will start looking at, why is your average PACU stay for lap pulleys, the anesthesia that you do, twice as long as hers? Why? And then they're going to start basing their reimbursement on your outcomes. It's coming. I'm telling you, it's coming down the road. There will be a time where that data will be judged, because remember, insurance, they don't follow HIPAA. Insurance companies are not required to follow HIPAA. It's not a requirement for them. They're exempt. So there's a free sharing of that information with insurance companies from hospitals. It's the way it's always been. They are going to get smart enough. They already are starting. Some of them are. And they've done it with physicians. They just haven't done it with us yet. But what they've done is they've started looking at individual provider outcomes. If for some reason your patients are going to the ICU and somebody else's aren't, then there's something wrong, right, with you. And then they're going to say, well, we're not going to pay this person. They could come to a point where they say, if this person is involved in an anesthetic, our ex-insurance company is not going to pay the bill. And so think about that. All of your decisions need to be evidence-based. That's what we're trying to teach you here, right, is evidence-based decision-making. I mean, skip measures, that freaked people out at first. We've always been exempt from DRGs for the most part because we can't control, we don't have control of the situation. And the reason why I say that is, if let's say there was DRGs in anesthesia, and I was gonna get paid $100 to do a lap chole, and I worked with Joe, surgeon, who could do a lap chole in 50 minutes. And we could do 5 of them in a day. But then another day, I work with, John over here, and he, or whatever, it takes him 3.5 hours to do a lap chole. And we do 2 a day. Is that fair to me? If I'm getting if I can make $500 working with this dude, and I can only make $200 working with this dude, it's not fair to me. So that's why we have a set fee amount per procedure, CPT code fee, and then we charge for units afterwards, which is time. So there's a built-in time that a reasonable amount of time, let's say it's 90 minutes for that lap chole. So then for every minute over that, used to be 15-minute increments, and everybody lied. Because what they do is they'd say, yep, let's wait. Can we leave in 2 minutes out of the operating room so I can get another quarter, so now it's just on plain minutes, on number of minutes to keep people from trying to cheat. So, so we get paid base units in addition to the base units for the procedure, and then you can look up base units because they're different for everywhere you go. So places with higher living expenses have more base units. And so let's say a lap chole is worth 6 base units or 8 base units. It's probably $20 in Florida. I don't know what it is. I don't do my own reimbursement. Because insurance companies, they do nothing but look for excuses not to pay you. That's why I don't do my own billing, right? Somebody else's headache, when I was doing that sort of stuff. When I was working in offices and stuff, I had a billing firm. I didn't care how much it cost to pay because I know CRNAs that spend their entire evening from the time they get home at work till 10 o'clock at night on the phone trying to, fix insurance things and whatever. So, and then working in facial plastics was pretty easy because that was all cash business. So,
what is your opinion on, or what are your thoughts on surgeons that swing between rooms and patients being anesthetized for sometimes upwards of an hour before the procedure starts?
I think it's unethical, but it's not going to change probably anytime soon. Now, what slowed them down a little bit was having to talk to people on the day of surgery. So when I was a CRNA back many years ago, surgeons would expect the patient to be on the table, asleep, prepped, and draped before they even got there, right? And if the patient, I had surgeons at the one place in my first job when I was at the Air Force that would say, well, they have questions they want to talk to you. Cancel them, have them go to the office, they can ask questions there. I don't have time for this. Okay? Then when patient safety goals came out, that's like they all lost their mind with timeout. They thought that was the dumbest thing they ever heard. I had surgeons say that. No way in hell I'm ever doing that. Of course, they're doing it today, right? I'm not doing that. That's baloney. And having to see the patient the day of the procedure has slowed them down a little bit. But yeah, they still bounce. Some places bounce back and forth. We don't do that at Mayo. Nothing at Mayo happens fast. So we have a few guys that work at Mayo with the intent of kind of honing their craft so they can bounce and go do something else somewhere else, but they're few and far between, But other places do that, and it's not right to have somebody on the table asleep for a long period of time waiting for a surgery. It's never, I've worked at places where you can't put the patient to sleep until the surgeon's available. I'm sorry, when as soon as you're available. But then they oftentimes, those guys that bounce back and forth, oftentimes have like a PA or something that's closing in the other room while they're ready to start in the other and stuff. So, but that's a management issue. The biggest problem that most hospitals have, other than Mayo, because Mayo is isolated, because the only people that work at Mayo are Mayo docs. There's no outside people that come in and do surgery there. Because when you work in a community place, community hospital, it's not the physician or the surgeon or whatever that dictates where the surgery is going to happen. It's the insurance company. The insurance company tells the surgeon where he's going to do the surgery, right? Because if, for example, he's on staff at Memorial Baptist and St. Vincent's, right, which would be murder probably to try to do that. But let's just say they were. And I needed to have a lap chole, and I went to Surgeon X and said, and he says, yep, you need to have your gallbladder out. The insurance company is going to say, do it at Memorial because we have a better deal with them, right? And I'm going to say, Memorial? really? But, you know, that's the way it is. Administrators still live in the 90s when surgeons actually had a choice of where they were going to do procedures at. So they still say, you know, piss me off and I'm not bringing any more cases here. It's not their choice. It's not their option. That decision's been made already. So instead of these places that cave for everything and treat surgeons like, you know, gods because they bring in income, they need to grow a set and tell these guys, hey, listen, you know, here's the deal. The only reason your patient's here is because our people negotiated a better contract than the other places you're on staff at, so shut your pie hole, you know? But they won't do it. But they won't because they're so afraid to make the surgeons angry. Plus they're the golf buddies of the administrators anyway. Don't think that that's not some sort of, I don't know, sociopathic plan on their part, you know, because they do. They're golf buddies, whatever buddies, fishing buddies, whatever. They purposely seek out relationships with administrators because then they can manipulate them. That's what they do, right? They don't really like them. They just manipulate them. Yeah. The worst job I've ever imagined ever having in my life would be one of those reps. Even though they make good money, those equipment reps and stuff, it's like, dude, I mean, I'm gonna tie a rope around your ankle so I can pull you out when this is, you know, before you get any further up there. You swallow your pride and it's so much fun in your job. It's awful. It's disgusting. It's sickening. You look at these guys and it's like, dude, really? Yeah. And the surgeons love it. They're just megalomaniacs anyway. They just want, they love attention. So.
You were continuing. You were saying base units plus and then.
Oh, base units plus time, right? So base units after whatever the time allotment is. It's really it's complicated. So you can look up base units. You can Google it, and there's actually a huge. It changes every year, and there's actually a huge book of what it is based on where you're at, and it'll say stupid stuff like under Florida, it'll say Miami-Dade County, say Broward County, Palm Beach County, maybe Hillsborough, probably not Duval, and then it'll say the rest of Florida, right? So if you're not in one of those other places, then you're the rest of Florida, right? Or it'll say, so it'll outline certain areas because it is more expensive to live in Miami than it is to live in Jackson, right? So you would expect that those base units probably be a little bit higher. Maybe $22 now instead of $20 now. It's not significant. Now New York City is probably 30, someplace like that. So, but and then there's a provision in there for time because obviously if he takes 3.5 hours to do a lap pulley, then after that hour that is allotted in the base units, then I need to be able to charge for that extra time. So that's everything. So you have to be really careful. If you decide to do your own billing, you have to be really, really careful. Medicare looks at stuff all the time with a fine-tooth comb, and if they even think for 1 second, or any private insurance company thinks for 1 second that you cheated them, they can bar you from or they can drop you from their provider list. And when you go to apply for jobs and you go for credentialing, they're going to ask if any insurance company, Medicare, Medicaid, anybody else has ever dropped you as a provider, right? They want to know that. Because then that's their way of knowing you probably were, cheating a little bit on your reimbursement and got caught. It's always easier to kind of, it's always tempting. I mean, to just, toss a couple extra minutes in there or whatever. People do it, and eventually you get caught. Talked about data. Quantitative researchers collect numerical or quantitative data, right? And qualitative researchers collect narrative or verbal data. So the important part about what you're going to be looking at in the studies that you decide to choose is you're going to be looking at that qualitative data that they picked up and whether or not that data was statistically significant. You're going to look at things like the N because, if you pick up a study, I've seen studies before, I said, well, that's a really good study, and the N is like 15. It's not a study, it's a pilot, 15 patients, really. Excuse me. There's a thing called power analysis. Everybody know what that is? Power analysis is to determine N. You can figure it out if you want to see if they were close. So The difference between quantitative data in the past week, how depressed would you say you are on a scale of 0 to 10, with 0 means none at all, 10 means most possible, so like a Likert type scale. And you have somebody rank themselves, subject 1 says 9, subject 2 says 0, subject 4. So obviously that's quantitative data. Qualitative would be just to ask them how you feel and listen to what they say. And then after you've talked to enough patients and you I wake up each morning and I can't think of anything to look forward to, right? That might be a common theme that you hear from people, right? So people who are depressed, that's pretty common. One of the highlights or biggest things you find in depression is something called anhedonia, which is a lack of finding anything pleasurable. So one of the things that they'll tell you is, it's like, well, tell me what you like to do. It's like, well, I used to, bowl or sew or whatever, but I just not interested in doing that anymore. That's one of those flags in depression that, one of the early things that you pick up on with people. Relationship, cause and effect relationships, we talked about independent, dependent variables. Associative, kind of functional relationships, those are more like not really cause and effect. Just, they're phenomenologically, fairly sound across data points. You find that by and large women live longer than men, right? They'll joke about why wives live longer than their husbands, or why husbands die before their wives. I'm sorry, because they want to. It's not true. I'm not good at jokes. I'm not even try. Experimental. Okay, so here's where we get into what's important. This is the point I want to make. The difference between experimental, quasi-experimental, and non-experimental research. Okay, you look at studies. You look at the title of it. It's just brings a tear to your eye because it's right up the alley of what you want to look at. But then you come to find out that it's maybe a convenient sample cohort, cross-sectional cohort study. That's not randomized, not double-blinded. There's really no controls since it's a convenient sample. And it's probably a level 4, 3 or 4 evidence. There you go. Right? Because the highest levels of evidence are the ones that are done under an experimental design. So under an experimental design, what are the things that you want to, so what's the point of doing an experimental design? What are you trying to prove by doing an experimental design?
Cause and effect.
Okay, trying to prove cause and effect, but you're also trying to do something else. You're trying to control, right, the situation so that if you randomize, you are now giving people an equal chance of being either in your control or your treatment group, right? If you randomize. If you blind whoever is doing the actual research itself. Let's say, for example, you want to do a study and you want to see whether or not 1% lidocaine or 0.2% ropivacaine, we're just making this up, stings less for the skin wheel before you start an IV, right? If you mark the little insulin syringes that people were using to make the skin wheel before they start the IV, one with lidocaine and one with ropivacaine, then now all of a sudden there's a chance that you're going to bias your people who are actually collecting your data, who are actually doing the procedure because they already know that lidocaine is better, right? So you don't want to do it. So if you blind it to them, right, which means you put A on one syringe and B on the other syringe, and they don't get to know which one is which, it's just like placebo effect, right? It's just like with placebos. You blind them, right? Double blinding means what? Right, so both of them don't know what anything is, right? So now you randomized them into treatment and control groups. There was an equal chance that they were in either group. You blinded the researchers themselves to prevent bias of any sorts on their part, right? So now really you have an experimental design. So now when you collect your data and then you crunch your data using inferential statistics, right? Because the purpose of inferential statistics is to infer that there was a change, right? So now you have the ability to generalize those findings to the population as a whole if you have a statistically significant difference, right? So if you're looking at a p-value of 0.01 or 0.05, depending on what you want, and you have statistically significant difference at a p of 0.01, then there's only, what, a 1% chance that this actually happened by chance, right? That it wasn't an actual method, like a methodical kind of finding that you found. Now, in what you're going to do in evidence-based practices, you're going to design an intervention based on evidence. It's going to be a convenient sample of patients who are not going to be randomized and not going to be blinded and not going to be controlled. It's a non-experimental design. So then when you come to me with your reams of inferential statistics telling me that there's a statistically significant difference between your groups, I'm going to say, why'd you waste your time doing that? Because it's non-experimental data. You can't infer, you cannot say that data derived from a non-experimental design is generalizable to the entire population. It doesn't work that way, right? So it worked in your situation at your time, and there's no problem with that. You write it up that way. That's how you write it up. It's still valuable information for other people to know. You just can't come out and say, because it worked for us, it's going to work for you. Make sense? Okay. So non-experimental designs are oftentimes lower levels of evidence, obviously, right? As opposed to experimental designs. Because experimental designs take control for confounding variables, they control for bias, they control for Hawthorne effect, they control for all of those things that to try to keep the data from being contaminated, right? So that's why in an evidence-based practice, pre-post intervention design that you're going to do is you're going to collect, hopefully, data mine retrospective data for a couple of months before, then you're going to put your intervention into place, and then you're going to look at the data forward from the point of the intervention, and your only comparison is with the pre and post intervention groups, right? There's no control group or treatment group. There's none of that stuff. You have a pre-intervention group, like let's say for the warming thing. We're going to look at 3 months of data before we instituted the use of the bear claw, whatever it's called, bear claw, the preoperative warming. Bear hugger makes it, but it's called bear claw is the preoperative warming gown, and it's a little thing that's mounted on an IV pole, and the patient actually controls it. So yeah, it is. They're awful. So, well, they don't want to keep on because it's like, it's like you go in the room every time and the damn thing's like inflated, standing sideways in the bed, because it's like too hot, you can't take it, you can't do it, So you take, so we're going to look at the 3 months of data of like admission to PACU temperatures, whatever you want to call it, before we do this educational intervention with the preoperative and holding nurses and staff about the importance of pre-warming. And then we're going to look for 3 months at that data after the intervention to see whether or not we were able to find a difference. We were able to make a difference. Because remember, in the end, our point and our plan is to improve outcomes, right? We're going to try the point or the purpose of your evidence-based practice project is to improve patient outcomes, right? So whatever that outcome is. Now, you have to have a measurable outcome, okay? And I'm going to tell you right off the bat that if you come to me and it has something, and the words feelings, beliefs, perceptions, thoughts, any of that stuff is involved, I'm going to say, no. Start over. I don't care. We all believe hand washing is important. We all perceive that germs and that germs are transmitted with dirty hands. We all think that hand washing is important, but I could sit and watch you in the operating room and identify probably 12 to 20 times in a day that you missed an opportunity to clean your hands. It's not because you do it on purpose, it's just because it happens, right? I do it too, you know? I mean, I was working at Mayo a couple weeks ago, and we woke the patient up. I didn't have gloves on. The bed was 180 degrees. The student was struggling because they extubated the patient and the patient learned spasm, right? I didn't have gloves on. I run down to help. The anesthesiologist is at the anesthesia machine. And I opened her mouth, shoved an airway in, you know, lifted her chin, you know, held onto her, and while the anesthesiologist squeezed the bag trying to break the laryngeal spasm, and she's coughing, and there's her on my hands, and I'm like, you know, like, what am I gonna do in that situation? I'm at the other, you know, my anesthesia machine is here, I'm down here with the student, helping them, right? There's no gloves in my general vicinity, you know, that I can grab and put on. And I'm like this, and I'm grabbing the airway, and I'm putting it in, I'm doing all kinds of stuff, and I'm like, I can't believe I'm doing an example of why with no gloves on. But it happens, right? It's not because I chose to do that, it's just the way the situation went. If I was smart, I would have put on gloves when it was time to wake up and just had left them on. But I didn't. So, yeah, there's gonna be opportunities where I obviously need to, you know, I'm not gonna not wash my hands after that, I can promise you. But those are opportunities. One of the things too is, you know, your mask that you wear is only good for 30 minutes, something like that, right? So when you work with me, I expect you to change your mask at every case, between every case, right? Not wear the same mask all day long, right? And what I have done in the past, when I know people have lied to me about whether they change their mask or not, is I take my Sharpie when they're in the room and I mark on the back of the tape of their mask. And then when I say, did you change your mask? And they say, yep. And I say, and I look and I say, LLPL, liar, liar, pants on fire. Don't lie to me. You know, change your mask between every case, right? That's a rule. So, anyway. And it only takes a second. As a matter of fact, when I come out of the room, and there's garbage cans all along by the scrub sinks at Mayo, as I'm coming out of the room with my patient, that thing comes off and goes in one of those garbage cans. It's gone, right? I don't talk to patients with masks around my neck either. That's really tacky. So.
What's the deal with, what's the deal with, why are the loop masks, what is the Joint Commission having against that?
I don't know. Do they?
Apparently some facilities, they're taking those away.
Really? I never liked them. I never really liked them that much because they're annoying. But
I just don't know, I don't understand what the
I
problem
don't know.
is.
They have these ones that Mayo, these duckbill masks, man, they're the best. I love those things. It's just like, because it's not like, it's not right up on your face. And those are nice. But yeah, if you don't like wearing a mask, you're in the wrong profession. I'm wearing a lot of masks. I'm not going to spend a lot of time talking about qualitative research, but in qualitative research, it's mostly grounded theory research, which tries to see and understand key social psychological processes. So the whole idea behind qualitative research is to try to find themes, looking for themes in conversations with people, and then pulling those themes out, and then trying to use that to determine phenomenologically why something is the way it is, why it is what's going on. In phenomenological research, your focus is on, phenomenology is the focus of the lived experience, right? So if I were to say, like, for example, if I was going to be doing qualitative research, to ask you about what are the factors that made you decide to apply to be where you are right now, right? So I could probably try to guess what those are, you know, but I probably would be better off if I sat down with everybody and let you explain it to me. And then take those 24 data sets of recorded conversations, listen to them all, and pick out themes of each one. And then I could say, here are the 5 main reasons why people are sitting here right now, right? The biggest mistake that anybody ever makes when they come to anesthesia school interview, it happens every year, somebody says, is, well, I want to be a CRNA because I'm tired of being a nurse. In a room full of nurses, that's not a good plan. Yeah, not good. So phases in a quantitative study, we're not even worried about. So in a qualitative study, qualitative studies require conceptualization and planning. So when you think about a qualitative study, you have to think about how you're going to do this. So one of the things that I'm working with a guy named Shane Halcomb, who works at the University of Miami, is we're looking at those preoperative predictors of problem postoperative pain, and it gets to be kind of a funny back and forth about looking at different types of studies that have looked at that, right? Everything from the one I told you about the IV stick and the visual analog scale, and then people complaining of pain more, they complain a lot of pain when they start their IV, they're probably going to be a problem postoperatively, stuff like that, to something called catastrophizing, people who ruminate and worry and think about things that are, that are bad. Yeah, we get those. There have been studies where they put people's hands in ice water to see how long they could stand to have their hand there, and then to try to see if that was any determinant about how much they could play in pain. So we're still conceptualizing planning because we're still building this pilot study to see if this tool that we've designed is even worth anything. And then you conduct the study, you do it. You identify the problem, you do your literature review, you select where you're going to do it, which we're doing it at University of Miami at Mayo, at University of Miami Hospital at Mayo. You develop an overall approach and you address any ethical issues that are involved. Obviously, there are studies out there too where they shock people and do stuff to see what their pain tolerance is. I'm not going to do that, right? I'm not going to say, hi, how are you? With my nerve stimulator to see if they scream, right? Not a good idea. So, although I work with an anesthesiologist. Well, my first job, the anesthesiologist used to give us breaks. And it was one of the reps for one of the orthopedic, I was in an orthopedic case. And so nerve stimulators, they normally have the wires and you can hook to the EKG patches, whatever. But then they also have a interchangeable, these poles, right? The little poles. Right? That's what I keep on my nerve stimulator. I just put on their head. I just put on their ear to see what's going on. So it was sitting, and I have my own nerve stimulator years ago. Companies used to give them away for free. Mine's like a museum piece, but it still works. And it's sitting over on the anesthesia machine. I go out for a break. While I'm in there, Dr. Resnick comes in and gives me a break, right? So this guy is crusty and old and just mean and just, yeah. And one of the reps, the orthopedic reps, steps right in front of him, like here, and he's sitting right here. He picks up my nerve stimulator on tetanus and hits him right here, like on his bare arm. The guy jumps and screams, "Don't put your butt in my face." I heard that story from every single person in the room when I got back. When I came back in the room, there was this whole really tense. When I walked into it, it was like, everybody's quiet, everybody's tense or whatever. My nerve stimulator just on tetanus, right, on the guy's arm. So, plan the study, identify the problem, your lit review, the sites, all that stuff. Ethical issues, again, a study where you're actually looking at just doing a survey with people is really not at any really high risk of any sort of psychological or physiological harm to people. If people cut from it or something, I don't know. And then when you conduct the study, it's really important to look at, to try to conceptualize everything that you need to look at so that you're not missing data sets. And I've never participated in a study where we didn't later on say, man, I wished I'd asked this, fill in the blank, It happens every single time. So the biggest take home is that I just want you to understand that the studies that you're going to be looking at, the stuff that you're going to use, is going to be mostly quantitative studies. Mostly, again, if you're looking at high levels of evidence, you're looking at meta-analyses and systematic reviews, right? Does anybody tell you what the difference is between a systematic review and a meta-analysis?
Meta-analysis is a compilation of systematic reviews?
Well, it does more, it's a statistical, kind of a statistical compilation of all of the studies. Systematic review basically says, here are the themes and things that you say. Meta-analysis actually takes and combines data sets and then reevaluates that data statistically to show you aggregated data points that they pull out of it. It's just a little bit more.
So you need a statistician for those.
Yeah. Systematic review in and of itself is a huge undertaking, right? So that's where Cochrane and Joanna Briggs Institute. Those are the two of the biggest places to look. We had an online librarian here, Stephanie Weiss, who unfortunately just left, and she was really, really great about coming in, and she moved to Texas, and she would come in and she would go over, spend an hour with you guys on search strategies, on how to find, and then the other thing that was really great about her was students could email her and say, listen, here are my keywords and I'm having trouble finding anything, and then she just, I mean, to her that was fun, going in and doing literature searches and trying to find things. And she'd say, oh, here's 17 articles I found, and she'd email them to the students and stuff. I don't know who's going to replace her. I have no idea what the deal is with that. She left, it was husband got a better job, got a job in Texas or something, so she didn't leave because she was mad or anything. She just left because life changes.
Thomas?
They're supposed to assign us somebody
Yeah, they said they were
to the college. So once I meet that person, then we'll talk. But the idea being that keep in mind that the fees that you pay with your tuition cover the library, right? They work for you, right? So, I mean, I wouldn't just say, hey, find this. You gotta make an attempt, try to find it yourself. But then, if you're having trouble with any search term, and there's a distinct possibility, like Dr. Self told you last week, that he had a great idea and we couldn't find anything. There's nothing out there. So there's no evidence, there's no project, right? So, any questions about anything? I think we're a little early, but I don't care. It doesn't matter. What do you guys have? What else?
Pharmacy at
Farm.
1.
Okay, because that was what they said you're doing.
Is it 1 or 4? The normal time?
Yeah,
Is it okay if you, I know you just kind of threw, can we go over the rest of it first, just so,
If you want.
yeah, do you mind?
No.
So you kind of halfway through said, this is good.
Well, because hardly anybody missed anything.
I know, but. You're just-